Welcome back to the deep dive. So today we're doing something a little different. We are shifting gears from our usual broad overviews and getting really laser focused.
That's right.
We're going to strip away the noise and just treat this purely as a high-yield revision session. If you're a resident, especially a plastic surgery resident prepping for board exams or the FRCS, this deep dive is, well, it's custom built for you.
Yeah, we're not just chatting today. This is a focused study session. The goal here is just to review the essential facts, the stuff you need to have on instant recall when you're under pressure in an exam.
Exactly. We're going to be talking about the clinical management of oral cavity malignancies. But before we jump in, just a quick request. If you are finding these deep dives helpful for your revision, please take a second to rate the show. It really helps get this material to more residents who need it.
It really does.
And if there's a specific topic you're struggling with, hand surgery, burns, you name it, leave us a comment. We want to know what you need to review next.
And look, this is maybe the most important thing for those of you actually sitting exams. You really, really need to look at that premium subscription.
Oh, absolutely. The free feed is great for the core knowledge, but the premium subscription is where we keep the journal club and clinical cases deep dives.
And that's where you apply this stuff.
Exactly. That's where we apply the knowledge to real-world scenarios and critical appraisal. You don't want to walk into Aviva without having practiced that application. So go get that subscription.
Consider it an investment in your passing grade. I mean, knowledge is one thing, but application is where you pass or fail.
Okay, let's unpack this. Today's topic, management of oral cavity malignancies. It feels like bread and butter plastics, but, the details really matter.
They certainly do. We're going to cover the anatomy, which is much stricter than people often assume, the pathology, including those really tricky pre-malignant lesions, management strategies, and then we'll walk up the reconstruction ladder.
Okay, let's start right there with the boundaries. This sounds basic, but I know examiners love to catch people out on it. So anatomically, what strictly defines the oral cavity when we're talking about malignancy?
It's very precise. Anteriorly, the oral cavity extends to the wet-dry border of the lips. That's your front line.
The wet-dry border.
Yep. If a lesion is anterior to that, it's a lip cancer, which is treated differently. It has to be behind that border.
Okay, and what about the back? Where does the oral cavity end and the oropharynx begin?
So posteriorly, it extends to the junction of the hard and soft palate, up top. And then, crucially, down below, it ends at the circumvallate papillae of the tongue.
Ah, the circumvallate papillae, that's the hard stop.
That is the absolute hard stop. Correct. Anything behind those papillae is the base of the tongue, and that's oropharynx.
And that distinction changes everything.
It changes your staging, your treatment, your prognosis, everything.
Okay, so wet-dry border to the circumvallate papillae. Now, what specific structures are contained within those boundaries? If I'm listing them off in an exam, what's on the checklist?
You've got to be systematic. I'd start from the outside and move in. You have the inner aspect of the lips and the buccal mucosa, the cheek lining.
Okay.
Then you have the alveolar ridges, but both the upper and lower gums. Then looking down, you've got the floor of the mouth.
Right.
Moving back, you hit the retromolar trigone. That's that small triangular area behind the back molars, often overlooked.
Easy to forget.
It is. Then the hard palate up top, and finally, the anterior two-thirds of the tongue.
Just the anterior two-thirds?
Correct, just the front two-thirds.
Yeah.
As you said, the posterior third falls into the oropharynx. That's a completely different conversation.
Okay, so that's our playing field. Now let's talk about the enemy. How significant is the burden of disease here?
It's significant. Oral malignancies account for roughly 30% of all head and neck cancers. So this isn't some obscure thing. You will see that.
And pathologically, what are we usually dealing with?
The vast, vast majority are squamous cell carcinomas, SCCs. I mean, you might catch a minor salivary gland tumor or mucosal melanoma, but for high-yield revision, you just assume SCC until proven otherwise.
And how do they typically present? What does the patient come in with?
Usually you're looking at non-healing ulcers or, mass lesions. That's the standard. A patient says they have a sore that just won't go away, but in more advanced tumors, you start to see functional deficits.
Like what?
Well, loose teeth are a big red flag.
Okay.
That implies the bone of the mandible or maxilla is being invaded. Trismus, or lockjaw, is another specific sign. It suggests the tumor has invaded the pterygoid muscles.
What about pain? Is it always local?
Not always. Refer to otologist, so pain in the ear is a classic sign of advanced disease.
Right, the nerve pathway is referring that pain. Now, we all know tobacco and alcohol. What other risk factors should be on our radar?
So beyond the big two, you've got local trauma, think chronic irritation from a sharp tooth. There's also a clear association with oral HPV-16, although that's even more prominent in the oropharynx.
And any culturally specific factors?
Betel nut usage. It's a major one to be aware of. Highly carcinogenic.
Okay, here we go. This is where it gets really interesting and where I think a lot of residents get grilled. Premalignant lesions. Specifically, the difference between leukoplakia and erythroplakia. Let's break this down very clearly. Start with leukoplakia.
Right, leukoplakia. So by definition, this is a white patch. The key clinical test, and this helps you distinguish it from, say, lichen planus or Candida, is that it cannot be scraped off.
It's adherent.
Exactly.
Yep.
And it's a diagnosis of exclusion. We diagnose it when the lesion can't be characterized as anything else.
And the risk profile. How worried should we be?
You should be moderately worried. Epithelial dysplasia is present in about 25% of biopsies, and up to 20% of these lesions will eventually undergo malignant transformation.
So management is biopsy.
Biopsy is essential. You can't just watch it without knowing what you're dealing with. If that biopsy shows dysplasia, it needs to be excised. If it's non-dysplastic, you can observe, but it has to be with strict follow-up.
Clear enough. Now compare that to erythroplakia.
Erythroplakia is a red patch. It has a soft, velvety texture.
Velvety. That's a good buzzword.
It is. And like leukoplakia, it's also a diagnosis of exclusion. However, the risk profile is significantly higher.
How much higher are we talking?
I mean, epithelial dysplasia or invasive SCC is present in almost all erythroplakia biopsies.
Almost all.
Yes. You see a red velvety patch, it's almost certainly already bad news. So the threshold for excision is much, much lower. You just don't sit on these.
Wow. Okay. White patch, 20% transformation risk. Red patch, almost always trouble.
Got it. What about genetics? Are there specific inherited syndromes we need to flag?
There are two key inherited conditions you need to know. The first is Fanconi's anemia.
What are the specifics there? It's a rare autosomal recessive disorder. It's more prevalent in Ashkenazi Jews and Afrikaners. These patients have a notoriously high risk of developing oral SCC.
And this happens young, doesn't it?
Yes, it can occur as early as 11 years old. And here's a specific trigger warning for the exams. The risk increases, particularly after stem cell transplantation.
That is a crucial detail.
Yeah.
What's the screening protocol?
They require screening for head and neck SCC every 3 months.
Every 3 months, okay. And the second syndrome?
Liefeld-Menu syndrome. This one's an autosomal dominant disorder, and it's linked to mutations in the p53 tumor suppressor gene.
And just to cover all the bases, what about acquired conditions?
Usually immunodeficiency states. So think AIDS, immunosuppressive medication, maybe poor nutrition.
Okay, let's move into the clinic. Patient presents with a suspicious lesion. Talk me through the workup.
First and foremost, management is planned by a multidisciplinary team, the MDT. And that includes the patient. You have to establish very early on, is our intent curative or is it palliative?
Right. History and exam are standard. What about imaging? What's the go-to?
MRI. MRI is the modality of choice for the oral cavity. It gives you the best soft tissue detail to assess, depth of invasion, especially into the tongue.
And for systemic spread?
You'll need a plain X-ray or a CT of the chest. You're looking for METs or maybe synchronous lung primaries. And of course, you stage the disease using the TNM system.
Now, what about panendoscopy? Do we scope everyone to look for other tumors?
That's actually a bit of a debate.
Oh, interesting.
Yeah, the literature suggests that routine panendoscopy to look for synchronous tumors is contentious.
Well,
It's not really a hard and fast rule anymore because the yield might not justify the risk and the cost in every single case.
good to know. So we've got the diagnosis, we've got the staging. Now we need to treat. Let's start with early disease T1 or small T2 tumors. Surgery or radiotherapy?
It depends. I mean, both can be effective. The choice is really influenced by a whole matrix of factors.
Such as?
Fitness for anesthesia is the big one,
Yeah.
obviously, but also tumor size, location, and the depth of invasion.
Does the anatomy play a role?
A huge role. Proximity to bone is a major factor. Radiotherapy can cause osteoradionecrosis, right? So if the tumor is right on the mandible, you might lean towards surgery to spare the bone from that radiation damage.
And I assume neck nodal status and patient choice also factor in?
Precisely.
Okay, that's early disease. What about advanced disease? T3, T4, or if there's nodal involvement?
The protocol shifts. We generally follow a pretty standard 4-step sequence.
Walk us through the steps.
Step 1, surgical resection of the primary. Step 2, neck dissection to clear the nodes. Step 3, reconstruction. And then step 4 is post-operative radiotherapy.
Is there a time limit on that radiotherapy?
Ideally, yes. It should start within 6 weeks of surgery. Delaying it beyond that can affect survival.
Okay, I want to double click on the surgery part, specifically margins. This is a critical board topic. What defines a clear margin versus a close margin?
Right. You have to distinguish between your goal in the operating room and the final result from the pathologist.
Explain that.
Well, the surgical goal is to resect with clinical margins of 1 centimeter. Obviously, vital structures might limit that, but 1 centimeter is the target.
And the histological definition, when the report comes back.
Histologically, a close margin is defined as less than 5 millimeters.
So if you get a report back and it says 4 millimeters.
That is a close margin, and the implication is that it usually requires adjuvant treatment, like more radiation or even further resection. You can't just ignore it.
Right. 1 centimeter target, less than 5 millimeters is close. Memorize those numbers. Okay, let's move to the final piece of the puzzle, reconstruction.
The reconstruction of the oral cavity is complex, but really it boils down to 4 main priorities.
What are they?
1, restore continuous lining. 2, maintain oral continence. You don't want the patient drooling. 3, maintain speech and swallowing. And 4, provide an acceptable aesthetic result.
Free tissue transfer is the mainstay here.
It is.
So let's compare the two big workhorses. The radial forearm flap, the RFF, versus the anterolateral thigh, the ALT.
A classic comparison. Let's start with the radial forearm. Its big advantage is that it's a large, thin, pliable flap,
Which makes it good for?
relining the mouth. Because it's so thin, it allows for better tongue mobility. You can also design multiple skin paddles with it.
And can you take bone with it?
You can, but the bone availability is minimal. It's usually just a partial thickness of the radius, so that's a limitation. Plus, the donor site on the arm can be troublesome. It often needs a skin graft and leaves a pretty visible scar.
Okay, so RFF then, pliable, but donor site issues and not much bone. What
Yeah.
about the ALT?
So the anterolateral thigh flap gives you a large volume of tissue. You can even include the vastus lateralis muscle if you need more bulk.
And the pedicle, the blood supply.
It has a long pedicle, which is great. It can be septocutaneous or musculocutaneous.
Is it too bulky for the mouth?
It can be. It depends on the patient's habitus.
Yeah.
But the advantage is that it can be thinned quite aggressively.
And the donor site.
Morbidity is minimal compared to the forearm. You can usually close it directly, and the main issue is just some numbness on the thigh.
So ALT gives you volume, a long pedicle, and low donor morbidity. Now, when they're plugging these flaps in, what are the common recipient vessels in the head and neck?
You have a few standard options: the facial artery, the superior thyroid artery, the superficial temporal artery, and the transverse cervical artery.
Okay. And just to wrap up the reconstruction ladder, if a free flap isn't an option, or for a smaller defect, what are the local or regional alternatives?
For local options, you could use local mucosal flaps or a FAM flap. That's the facial artery musculomucosal flap.
And for regional?
The pectoralis major flap is the classic sturdy backup. It's bulky, but it's very reliable. You've also got the delta pectoral flap or the nasolabial flap.
And for the really small defects?
Often direct closure or skin grafts are all you need.
Okay, let's do a quick recap. We've covered a lot of ground here. We defined the oral cavity boundaries, remember, wet-dry border to circumvallate papillae.
We distinguished leukoplakia, the white patch you can't scrape off from erythroplakia, the red velvety patch that is almost certainly dysplasia or cancer.
We nailed down the margin rule. Aim for 1 centimeter clinically, but anything less than 5 millimeters histologically is close and needs action.
And we compared the RFF, thin and pliable, with the ALT, bulky but thinnable, with low donor site morbidity.
That's a solid foundation for the boards. Now, before we go, consider this.
We mentioned that routine panendoscopy is considered contentious. If you're sitting for an exam, ask yourself why. Why might the yield of finding a synchronous tumor not justify the risk or cost of the procedure in every single case? It's worth thinking about the balance of evidence there.
A great question to ponder. And remember, if you want to see how these facts apply to actual patient scenarios, you need to listen to our clinical cases episodes. They are only available on the premium subscription, so go sign up now.
It's the best way to test your knowledge before the real thing.
Thanks for listening to this deep dive. Good luck with your revision, and we'll see you in the next one.